I'll just request Dr. Ra again to talk about technical tips for stumpless BTK lesions. And this is a very common scenario we see in India also, especially in Berger's disease. We really don't have any clue where to start our wiring and where to get the channel and to start the procedure. So Dr. Ra, again, to your wonderful techniques, we would like to be enlightened by you.
Actually, there will be two stumpless. One is the proximal stumpless, the other is no distal stump. So I cannot handle everything today within 10 minutes. So just today, you can see something in the proximal area in the below knee. However, no distal stump to connect. But the patient coming a high chance of amputation, then what we have to do? There's no surgical option, no bypass option, no clues for the intervention. But we have to save the patient. How we can do? That is the issue for today's presentation. So this is what I developed. Initially, we can do APVIC 14 intraluminal wiring or the subintimal wiring or some partly flushing technique and something going not smoothly, the 14 subintimal wiring, especially below ankle, and contrary to transpedal approach or transcollateral approach, we can do in a blind approach in the distal circulation. No visible distal stump. These are my method developed by myself for more than 15 years, challenge for the BTK and no distal stump. Most of the case I can solve by this, my own technique. So first of all, you should be very friendly in the BTK below the ankle CT wiring. So key issue is the intraluminal wiring. My friend, the first option is to use this 3.5 command ES 14 wire for the BTK below ankle. This is a hydrophilic, very useful because this is not easily going outside of vessel wall. Unlike the CT wire from Asahi, that can easily, for example, Astato series or something other stiffer wire can go outside. Like Halberd or some other CT wire, but this cannot go outside. To maintain inside of the vascular area is very important for the safety. And this stiffer wire, especially the 1.0 gram, this is good for negotiable distal circulation. And the V18, this is good due to strong shaft support. I like this for the retrograde approach for delivery of microcatheter due to the overcoming the angle of the subcutaneous from the retrograde access. Sometimes we can use the 18 wire for the better shaft support. So basically, angle distal, less angle is important than the higher EZ angle not to disturbed by the side branch. And subintimal tracking, 1.5J thermo wire is good to maintain a smaller subintimal space. Supporting device, I like angiocatheter, multipurpose or the microcatheter. So basically, wiring is the important. First of all, wire selection. Instead of a penetration strategy, I like a sliding visible or invisible channel. Sliding technique is more safer. And once the sliding technique fails, then we have to go for subintimal tracking. At least the subintimal angioplasty, they can be maintained in the vascular space, not going outside. So 4 or 5 French especially multipurpose one catheter, little angulation, that is good for providing support for the subintimal tracking, and using microcatheter, the introducer is good for intraluminal CT wiring. And 3.5 thermo wire, directly we can switch it. Once failed the 14 system, directly switch it to 3.5 subintimal tracking. And this is not good for subintimal tracking. We can make a bigger subintimal tracking, making bigger space. And this is good for more 1.5 5 millimeter small loop thermal wire is good for subintimal preformed loop. So I like a 5 French short shapes ipsilateral approach, avoiding thermoshes. This is not good for ipsilateral contrast injection after insertion of a 5 French guiding catheter. Too tight. So Saint Jude or Cordis sheaths will be better than thermoshes. 5 French MP support or the sometimes microcatheter 18, any microcatheter and the intraluminal 14 wiring failed, then subintimal 35 and 5 French heart rate catheter or the Endure catheter from Korea with Y connector and the BTK ballooning, at least 2 to 3 minutes for prolonged balloon inflation. Sometimes long, at least 200 millimeter balloon, prolonged balloon. Korean patients 2.53 in the proximal and 1.5 to 2.0, and below ankle 1.5. And mostly these days, tapered balloon I'm using 2.5, 2.0, more than 200 millimeter. Let's see the sample case. This looks like a ATA total, PTA total, proximal total occlusion, but stump are visible. Distal basically no connectable stump. Where are the distal stump? One by one, just this on the fluoroscopic calcification, we can see that this is ATA stump. This is looks like a peroneal stump. This is some branches here, but the ATA, the PTA maybe, this is maybe junction of a entry point of a stump. So we briefly assume that this is a multi-purpose, my favorite supporting catheter, and focal calcification, this is 1.5J. Long total occlusion, no distal ATA stump, just blind loop, smaller loop. This is important. Small loop and making pullback and making the distal loop size smaller. The smaller, maintaining smaller loop is very important because that can create a very smaller subintimal space. The smaller the subintimal space, you can make a good intraluminal. And below ankle level, it's better to not to push more aggressively, not going down to the below ankle level, because sometimes this angulated portion, you can create rupture. So around this ankle level, malleolus level, I don't push it down. At this bended area, just to stop the subintimal tracking, then just stop and remove this multi-purpose angiocatheter, then just insert this guiding catheter, 5 French, removing angiocatheter, and along with this heart thermal wire, I'm delivering this heart rate catheter and removing this angioplasty, the previous thermal catheter, then just a gentle contrast touch. Usually most of the distal area, invisible distal channel, more than 50% I can easily find out the distal channel. This is the best benefit of blind subintimal tracking below the ankle. Then what we are doing, just a simple 14 wiring. This is easy. Just the command wiring, then do the balloon angioplasty, 2.5, long balloon inflation 2 to 3 minutes, and the 2.0 and 1.5 to below angle. This is easy and prolonged inflation. And you can see the good flow from ATA proximal to the distal. Those are the pedicel and the good circulation to the every digital space. And this is what I've done. So 3-5 subintimal wiring, the proximal stump to the distal, hope are successful. I cannot show all the steps, but just from one patient. And this is second here. Let's see what I have done. This is a blind stump here. And we can start from the multipurpose, however, this directly heart rate support and making loop. And I found this subintimal entry with the 3-5 system, and for the subintimal tracking with the 1.5J thermo going down, and this heart rate following this subintimal loop space, and again this with the forceful push of this 1.5J, and until the ankle level, remove this pteron wire, you can see that just, however, this area not clear as the AT distal. And then it's time to empirical CT wiring with the 14 command ES wire. From this level, blind soaking, and you can prove in this 14 hydrophilic command 3.5 gram distal tip, I can prove every branches. Where is so I'm just seeking, and there's partly this looped wire of the distal tip of the command ES, and suddenly enter to the digital artery to the first toe. So just you can feel the tactile is, this is intralumen, and there's something, and the wire tip entered into far distal good true lumen. And then just starting again the same balloon, long inflation from the proximal post-tibial artery to the distal area, and the long balloon inflation, and the distal good run-up you can identify. And this communicating vessel showing this peroneal distal vessel, and once you open up the major tibial vessel, then you can get more good clues. And the proximal, then we have done this distal combination of a subintimal tracking plus 140 intraluminal wiring and POVA. And the last one, this is a peroneal total occlusion, and this is a very unfavorable approach, abrupt side branch termination. Exact proximal stump is not feasible. However, the best advantage of this loop wire technique, you can see just simply push, and this is easily can go down with the bigger loop, go down to the straight down. So maintaining vascular space straight down, maintaining axis toward the given anatomical direction is a very useful method by the subintimal tracking. Same fashion, we could do this just the 40 wiring and delivering same balloon, and this finishing in this ankle level and completely opened up this peroneal territory. So after this 3 vessel, quickly, this is a initial, this is the final angiography. So completely vascularization was achieved easily. I think that this is less than 30 minutes we can finish the BTK total revascularization. Usually not clear the distal wounded patients, no distal foot circulation clearly, however, after 3 vessels. But I showed just 2 options or 3 combinations. But using this 5 combination, the most BTK without distal stump, I can solve the problem. So I recommend you to adopt many combinations of our below subintimal tracking and the contralateral speed approach and the flushing with the gentle contrast injection, every method, and most of the no distal stump, you can solve the problem. Thank you for your kind attention.
Thank you, Dr. Ra. That was very wonderful, and we have learned a lot of techniques on endovascular interventions from you.